finally, we want to have the Africa Center for Health Systems and Gender Justice. This is an organization that was formed by Dr. Stella Bosire, who is the doctor lawyer, and having grown up in an unjust society in Kibera, I think she's giving back and seeing also the gender aspect. They want to discuss, they'll introduce themselves, rethinking women as health system financiers, and because we are in KOGS Central, where we deal with women, we welcome you. Would I introduce watu wako? Do you need the slides? Okay.
Hello everyone. Najua ni jioni. Hello everyone. Good. My name is Esther Mutanu. I work at the Africa Center for Health Systems and Gender Justice. Receive greetings from Dr. Stella Bosire. She's our ED. I know it's a bit intimidating for me to speak after doctors. I have seen things that I'm sure I wouldn't have seen on TikTok. So happy to be here. I have learned a lot. Yes, so we are here to have a conversation under the theme of healthcare financing. So trying to explore a different lens when it comes to financing and the role that women and households play when it comes to financing for healthcare. But before that, I would love to introduce the center and our work, and then my colleague will take us through our conversation for the day. Great, thank you. So the Africa Center for Health Systems and Gender Justice, we are an African social enterprise organization that works with women, grassroots women, and marginalized communities, trying to empower them economically, for them to be able to make better health decisions, and also for them to be able to access healthcare on their own terms. So we have our model, which is in three. One, we catalyze. By catalyze, we work with organizations that are working with grassroots women, where we are able to give them a bit of money for them to be able to empower the women they are working with the goal that the women will be able to make better health decisions for themselves. And then two, we also equip the women that we work with. So we take them through different programs. We are able to also give them some money, some grants, for them to be able to go and implement different programs for other women in the communities, with the hope that they're able to also empower thousands and thousands in their community, for them to also be able to afford healthcare and also to make better healthcare decisions for themselves and their families as well. Lastly, we also have a pillar called Amplify, which is basically what we are doing here. We speak about our work in different setups and different conferences. We also have our women come to speak in different conferences just to share their lived experiences, to speak about the work that we are doing and also the impact that we have in the different communities. This is just a highlight of some of our programs. The first one is Economics. That one lies under Catalyze. We are working with 7 grassroots organizations in Nairobi, where we have been able to give them sub-grants for them to support women that they work with in their communities. We have Femdigenomics, where we are doing a bit of research to be able to influence policies when it comes to healthcare, and also to have a data pool where people are able to get references when it comes to the situation of healthcare in the communities. We have the Ubuntu Health Leadership Hub, where we are working with 20 grassroots women, where we take them through different workshops, different trainings, just to empower them, for them to go and take that information that we give them back to their communities. They also get some sub-grants for them to go and implement some programs in their communities as well. We have Care for Equality, where we work with different healthcare providers like yourself that help us to take our work out there. When you are in these gatherings and we are not able to be there, we at least have people in our programs that are able to speak about our work. We also have the Health Hub, where still working with grassroots organizations to help them learn and also to empower them. And then lastly, we are also a philanthropic advisor, where we work with different donors and taking this conversation that we are bringing here of how women the center of healthcare and how they are shaping the systems and how that situation looks like on the ground. So we also work with different donors and different foundations just to be able to bring lived realities into those rooms where those women might not be able to get into. So what are the objectives of our conversation today? One, we want to speak about the lived realities of these women, just to open our minds to see beyond medical and the hospital situation, just to be able to bring the situations that these women are going through, and also to be able to understand what do they have to lose for them to be able to access healthcare. Some of them have to not pay rent, others have to not pay school fees, so just trying to understand that dynamic. And then second, we also want to bring a conversation around the role that unpaid care work that these women provide. What role does it play when it comes to shaping systems, and also how does that shape the access to healthcare for these women and their families? And then lastly, we also want to discuss how can we include that information, those lived realities when it comes to shaping systems and being able to transform this into healthcare financing that is equitable, responsive, and gender intentional. Thank you so much. I will welcome my colleague to take us to the next part.
Thank you, Esther. That's my colleague. My name is Dorothy Chepkoech. I also work at the center with Dr. Stella. So as she has introduced, we are not going to talk about the medical jargon. I was so shocked to hear about a molar pregnancy. I had to quickly Google it because I thought it's someone whose baby has teeth or something. So yeah, we've had quite an interesting day today. So the financing disconnect that we're talking about here, even nationally, we see that the formal system only looks at the national insurance. Like when they are doing SHISHA, they only look at the national outlook. Do they go to the grassroots communities? Do they go to the marginalized communities? I heard there's a colleague here from Isiolo, and they can see how marginalized communities are usually left out. We talk about public health budgets. We talk about donor and development investments like USAID, etc. But when it boils down to the household, we see out-of-pocket payments that are made by families for them to be able to finance their healthcare. We see informal borrowing. So many of our women in our community we know are in Chamas, and when they get a hefty bill to go do a myomectomy, the women in the Chamas have to come together and pool their resources for them to be able to finance something that is literally, their lives depend on it. And then we have unpaid care work, largely by women. So that's why at the center we see women as the invisible financiers of healthcare. They manage resources at the household level. See, we know even our moms used to be the one who used to say, this money is for food, this money is to take you to school, this money is for you to go to hospital. So they're the ones who dictate the budgets. So they are a key decision maker in this process. They're the ones who absorb shocks. We've said about the Chamas, we've said about women coming to see, even our moms, you see them coming, women coming to ask our moms, yeah, my so-and-so is in the hospital, kindly chip in. They're the one who mobilize the networks, like we've said, the Chamas, the savings group, the community, small meetings. And then now there's delivering unpaid care. So for example, if you have to release a patient early from a surgery in hospital, who does the work of taking care of that person? They usually go back home to their moms for them to do that work, to take care of them, to clean them up, to ensure they take their medicine, to ensure that their nutrition is on point. That's unpaid care work. We might look at it and say, oh no, but that's what they're supposed to do. But no, it would have been a burden on the healthcare system. If we look at it, if this person had to stay in hospital, it would have been a burden on the healthcare system. So literally it translates to unpaid care work. So women also have to see the impossible trade-offs that we have. There's healthcare versus school fees. How many times do women have to go get off-the-counter medicine? Because they know they can't go pay for the doctor. The doctor writes for them a hemogram, at least unajua, a stool test. You're given so many tests to do. Paka anasema hapana, let me just go to the pharmacist for the pharmacist to guess and see, hey, umekuwa ukisikia aje, you know, they guess something and then they give you a medicine, maybe it works as a placebo, and then you move on. But you see in adverse cases of the things we've seen here of the laparoscopy, you see those things, it might end up getting worse, and then you require such an expensive procedure. You may mention vizuri. Nice. So yeah, same as healthcare versus food. In some marginalized communities, in poverty-stricken areas where we work, Kibera, Mathare, I mean, the choice is between getting food and getting healthcare. Si utaambiwa uvumilie. Especially now when we talk about painful periods. I've had iko na jina, but painful periods that maybe it's endometriosis that has not been detected. You're normally taken to a chemist, unapatiwa, hiyo jina inaanza na onda something, a very strong painkiller, and then you move on with life. And that happens month on month, and the situation keeps getting worse. Healthcare versus rent. Rent in Kibera might be 2,000, but that is really hard for some people to raise. And that's some of the decisions that the women have to face every day. So when it comes to community financing, as I've mentioned, there's the Chamas and savings group where there's pooled resources for emergency costs. There's social borrowing networks. Sometimes these are Shylocks who end up harassing you after you borrow money, and you end up paying much more than what was required. And then there's the collective action, organizing care. Women come together, they carry the person, they make sure the person has gotten into hospital, they pay for the motorbike, etc. And that's the collective action that we're talking about, especially in the communities and in informal settlements. But this access is obviously unequal. The poorest and the most marginalized women are the ones who often cannot make their contribution requirements, and this deepens their exclusion. There's some data that is not even there with SHA about women who cannot be able to access healthcare because they don't know they even exist. Even these women don't even know what you're talking about when you talk about SHA. Yet, there are some people who are privileged and they are the ones who can make calls, approve your SHA, you see? There's a disconnect that happens from the people who really need this collective care. So women are not passive beneficiaries, and they have been financing this by all the things that I've said. So in our ward, what do we see every day that causes delays? So there's someone who doesn't have insurance, so the patient is either delayed or turns away. So they arrive, I mean, they would have come before their situation would have gotten worse, but now they go back because they're like, no, I don't have insurance, I can't afford all these things they're saying. So they come later where they are sicker and it costs more to treat than it would have costed them, and the outcomes end up being worse. And then there's the partial payment at discharge. The families, you see them negotiating at with the cashier, literally. Of course, sometimes maybe the doctors don't know about these things, but sometimes they do. And then sometimes they leave against medical advice. I know you've seen that so many times. Like, they have to leave because they know they can't afford, but it's against medical advice. And then, of course, the gaps in SHA coverage. Sometimes they don't cover chronic illnesses. Mental health is definitely not covered, yet even in maternal issues, postpartum depression ends up being serious for some people, and it leaves families exposed. So the costs that shape healthcare, so sometimes you have stage 3 presentations, like I've said, that should have been stage 1, and the cost was the delay. Drug adherence, some people are supposed to take a course of medicine, but because they can't afford all the medicine, they break the course. Mothers keeping postnatal follow-up, especially postnatal, if they give birth and they're like, oh, so I think I'm fine. If anything small happens, they try to put that at the back of their mind because they can't afford. And then she was managing at home, is most of us normally hear that because of the unpaid care work that I've said. There's someone that comes around and tries and sees with their eyes if you're doing well, etc. So better financing design, which is what the center pushes for, is going to boil down to better health outcomes. The programs that my colleague Esther has mentioned for her economics, where we give grants to community-based organizations, empower women to be able to make decisions for themselves. And that's the work that we try to push, because we know that women ultimately are the ones who are going to carry the burden. So for us to be able to reframe this conversation, and I'm sure for you, you'll be able to even be in other rooms and hopefully be ambassadors and mention this, is that decisions are made in households. They're not made in hospitals, because families at that level, they choose between survival and getting treatment. And then communities already finance care invisibly, and better financing design will result into better outcomes. So having that at the back of our minds, will be able to even lessen the burden on our national healthcare, because when we know that decisions made at the lowest levels, even in terms of preventive care, are going to be able to lessen the burden eventually, and are going to lead to more women, for us not losing women when it comes to that. So as I've mentioned, the expected outcomes, when women are not passive beneficiaries, but they're primary financiers and stabilizers of health systems. Want to make the gaps visible. So where the formal health financing diverges from lived community realities. There are so many situations that are put in the limelight, but not with the lived reality of the person, because that's a major part that exists. And then stronger cross-sector dialogue, like doctors versus us who don't know molar pregnancy. It actually really helps for us to see different perspectives of the same thing. Because you see a patient, but for us, when you see a woman, we see their struggles, we see the husband making decisions for her not to come to hospital in order to save money, and so many other aspects that can be contributing to the outcome of their health decision. So so we want to build financing from the ground up by ensuring women have money in their pockets, basically. That's the goal of all our programs. And we are still here, and we'll be happy to hear from all of you. And thank you for your time and your attention. Thank you.